We are live. We can start now.
Welcome everyone to the monthly academic series conducted by AFPI Kerala North Zone. It's a great pleasure and excitement as we are here inaugurating the beginning of our monthly CME. Without much delay, let me invite Dr. Prashok, AFPI Kerala North Zone President, to give away the presidential address. Dr. Prashok, please unmute yourself. Dr. Prashok, I think it's still muted.
He's asking to unmute, right?
Serin sir, can you please make him co-host? Okay.
Hi. Can you hear me?
Yes.
Okay. Good evening, all. Actually, I'm Dr. Prashok, AFPI North Zone President. I'm really happy to be here because this is the first event we are conducting. AFPI North Zone Kerala North Zone is conducting this year. It's my responsibility is to deliver the welcome speech. Actually, this is the first event we are organizing, and we are planning to conduct a series of events, academic and non-academic, in the future. So on behalf of AFPI North Zone, I would like to welcome Dr. Indu Raju. She's AFPI Kerala President. She is inaugurating this function. Next, I would like welcome Indu Madam. Next, I would like to welcome Rashmi Madam. She's Dr. Rashmi Kaimal. She's Treasurer of AFPI National Group. Welcome, Rashmi Madam. Next, I would like to welcome Dr. Serin. He's all in AFPI. He's former secretary, now representing India in Spice Route events. And next, I would like to welcome Dr. Kailas. He's secretary, AFPI Kerala. Next, welcome all. And next, I would like to welcome Dr. Danin. He's my childhood friend. He's academically excellent person in my friend list. He's delivering wonderful sessions in diabetic nephropathy. I think everybody will enjoy it. And welcome, Danin. Next, I would like to welcome Dr. Bijay Raj. He's chairing this session. And I don't want to say about him because he's the heart of AFPI. And the last and not least, all the participants who are coming here to join with us, because this won't be the last event. We are planning to conduct a series of events. So without participants, any CMEs, no CME won't be successful without participants. So I'm not lengthening my speech because of the time limit. So next, I would like to welcome Dr. Indu Raju. She's AFPI Kerala President to inaugurate this small session.
Thank you, Dr. Prashok, for the introduction. This is our second academic event of the induction of the new executive body. I'm really proud to see the activities of each zone of AFPI Kerala chapter. I request you all to keep in this space, not only in the academic activities, but also your valuable contribution in other areas like sports, media, newsletter, research, okay, etc. So it will definitely boost our confidence and mental strength too. Now, recently we have celebrated our World Family Doctors Day on May 19th, and I was happy to see the participation of all the members, PG institutions in various competitions conducted by the National Executive, and hope we grab a lot of prizes this time. And once again, I would like to thank North-Zone AFPI Kerala chapter for initiating this academic event. So we have a wonderful academic feast by Dr. Danim, Assistant Professor Nephrology, Government Medical College, Kannur. Welcome, Doctor. And now I declare this session inaugurated and open. Thank you.
Thank you, Indu ma'am, for that speech, and thank you for inaugurating this event. Next, I would like to invite Dr. Reshmi S. Kaimal, our dear Reshmi madam, to felicitate the gathering. Kindly unmute Reshmi ma'am. Dr. Sarin, kindly unmute Reshmi.
Good evening, all. So proud and happy to be part of this event, especially the academic series by North Zone. I think the North Zone was a bit dormant in the beginning. AFPI Kerala North Zone was a bit dormant since last 2-3 years, but I hope this academic series planned by the AFPI Kerala North Zone will rejuvenate all of them, and also the other zones to keep pace with that. So, and today's topic is especially very useful to all the postgraduate residents and practicing family medicine specialists too. So, without delay, let's move on to the next in the talk. I congratulate the North Zone and all the office bearers of the AFPI Kerala North Zone for this. Thank you.
Thank you, Reshmi ma'am. Thank you, Reshmi ma'am. Next, I invite Dr. Sarin. As already said, he's the all-in-all in AFPI, and also he's from Spice Route, India. Dr. Sarin, kindly give a few words.
Good evening, all. Really happy to be a part of this. And I'm really happy to see the number of participants as well, despite having multiple events in a single month. So I wish all the best to AFPI North Kerala team, North Zone team, and I really hope that we will have more such sessions in the near future. And I really hope that this will be a regular academic activity at zonal level. And all the best once again. Thank you.
Thank you, Sarin sir. Next, I want to invite Dr. Kailas P. He's a secretary of AFPI Kerala to give a few words. Kindly unmute Dr. Kailas.
Hello. Am I audible now?
Yes, you are.
Yeah, it gives me a very big pleasure to see such a wonderful evening hosted by the AFPI Kerala North Zone. So this is basically after taking charge by the new EV, this is the first time they are hosting an event, and I am very surprised and very happy to see the response for this event. And I also thank Dr. Danin for joining us and helping us with the nephrological doubts in primary care. And thank you, Dr. Prashop, Nigesh, and team for organizing the team. Okay. Over to you, Navina.
Thank you, Dr. Kailas. Thank you each and everyone who have come here to attend this session. Without much delay, before we go on to our academic session, I would like to tell that today's chair is one of a very famous family physician. We have Dr. Vijay Raj with us. We are extremely happy to have you, sir, here. Today, the guest of the day, our distinguished speaker is Dr. Danin Pudiotil. He is an expert in the field of nephrology. He did his MBBS and MD General Medicine from Government Medical College, Calicut, and DM Nephrology from JIPMER, Puducherry. Let's hear from him about diabetic nephropathy in primary care. Over to you, sir.
Hello, can you hear me? Hello.
Yes, sir, you're audible.
Yeah. Thank you all. Thank you all. Thank you for the nice words, and thank you all the office bearers and seniors and colleagues of the Family Physician Northern Zone chapter. Thank you for giving me this opportunity. So, coming to the topic of diabetic nephropathy, this session is going to be a very brief discussion of some practical points of primary diabetic nephropathy care only. I'm not going to the details of any algorithms or treatment protocols or guidelines that come across every now and then in diabetic nephropathy care. So this is going to be very basic diabetic nephropathy care, or an approach to, or you can say how I see my patients in diabetic patients presents with when I suspect kidney disease. And most of the things you might be knowing. And so why did I choose this topic? Diabetic nephropathy is the commonest, or diabetic kidney disease is the commonest cause of end-stage renal disease. If you go to any dialysis unit, more than 50% of the patients will be diabetic kidney disease. Why? Because diabetic patients are living longer enough to reach end-stage renal disease because of the proper care and proper diabetic management and proper risk reduction of cardiovascular risk reduction. These patients are living longer to reach the end-stage renal disease, and most of the patients of the dialysis population are diabetic patients. And these patients are asymptomatic till the last stage. Most of the patients coming to nephrology department are at the end stage kidney disease. So we know, and all of us know the practical difficulties when a patient reaches the OPD or clinic with a creatinine of more than 15, with fluid load, with fluid load, and with all features of uremic symptoms, without an access for dialysis, without a plan for renal replacement therapy. So it is the primary responsibility of the primary care physician who sees the patient for the first time, who attends or who manages the diabetic care for that patient, to address the disease onset and to diagnose and to properly explain the patient regarding the diabetic nephropathy part also. And there are better treatment options available right now. So we should try to take care of decreasing the progression, decreasing the rate of progression. So once the diabetic kidney disease settles, it eventually progresses. So what we are all trying to do is trying to reduce the rate of progression. And there are a lot of medicines and a lot of options available to reduce the progression, and we should try in our patients. So once there is a diabetic milieu, there will be advanced glycosylation end products, there will be hemodynamic changes, inflammation, growth factors, mediators, activation of renin system, and this leads to glomerular hyperfiltration, renal hypertrophy, glomerular hypertension, and this will lead to albuminuria, deposition, and this will lead to finally glomerulosclerosis, interstitial fibrosis, and CKD. Morphologically, when you say diabetic kidney disease, the patient should have either increase in creatinine or the proteinuria. And histologically, the patient will have mild increase in kidney size and expansion of the mesangium. And one of the earliest changes will be the thickening of the glomerular basement membrane. And Kimmel seal and Wilson nodular lesions will be seen in, and it might be pathognomonic, but it is not seen in all of the patients, 10 to 50% only. And vascular lesions, both afferent and efferent arterial hyalinose also can be seen in diabetic kidney disease. So the primary point in progression of diabetic kidney disease is proteinuria. So if the patient develops proteinuria, that indicates that the patient already started the progression. Already the patient is in the process of progressing to end-stage renal disease or diabetic kidney disease. So the core of the management or diagnosis or follow-up of diabetic patients, all of the patients are assessment of proteinuria. So we have a lot of measures to assess proteinuria. So previously it was like we used to tell normoalbuminuria and microalbuminuria and macroalbuminuria. When the proteinuria, if the 24-hour urine protein is less than 30 milligram per 24 hour, it was microalbuminuria, less normoalbuminuria, and if 30 to 300, it was microalbuminuria and macroalbuminuria. Presently, this classification is not there, and this is replaced by moderately increasing proteinuria, because even microalbuminuria, the previous concept was once the patient progresses from microalbuminuria to macroalbuminuria, there will be progression of diabetic kidney disease. It is not like now. Even the minimum amount of proteinuria is significant, and proteinuria is a continuum. There is no such a cutoff like when 300 is there, it is micro, and when more than 300, it progresses. So it is a continuum. So it is moderate. It is proteinuria, moderately increased proteinuria. So the term microalbuminuria is replaced by moderately increased proteinuria, and we have lot of measures to monitor the proteinuria. We have 24-hour urine protein, which is supposed to be the best marker, best to assess the proteinuria, but it is cumbersome procedure, difficult to do in OPD daily basis and follow-up basis. So we have spot urine PCR and ACR, urine protein creatinine ratio and albumin creatinine ratio, and urine dipstick tests are there, which are not based on creatinine, and urine dipstick, urine basic test. When you have on spot urine examination, you will get 2+, 3+ like reports you will get, or you can have microalbumin test also now available. So the thing is, whatever we do to assess the proteinuria, we should follow up. If we are using urine routine or dipstick test as a proteinuria assessment, and we'll follow up with the same thing only. The important thing is to follow up with the, okay, you are assessing with ACR, okay, you will assess the ACR in the follow coming months also. So you'll get an idea whether the proteinuria is increasing or decreasing, or there is no such a hard and fast rule that the ACR or is better than PCR, or 24-hour urine protein should be done all patients. So we have to assess the proteinuria initially, and we have to follow up the patient with proteinuria. Initially it was urine 3+, now it is coming to 3+, 2+, or coming down, or it is increasing. According to that, we have to make modification in the management of diabetic nephropathy. So how to diagnose diabetic nephropathy? There is no hard and fast rule there is no clinical criteria to diagnose. So the diagnosis of diabetic nephropathy is basically clinical. We should have the idea of natural history and timeline of type 1 diabetes mellitus and type 2 diabetes mellitus. So most of the patients, if previously they have assessed in type 1 diabetes patients, they were not on treatment, they were not on AC inhibitors, they found how 15 to 20 years they used to get proteinuria, and around 20 years they used to develop early initial stages of worsening of GFR. So it is almost similar in type 1 diabetes mellitus and type 2 diabetes mellitus. The duration to onset of proteinuria and CKD is almost similar, but the problem is we don't know the onset of type 2 diabetes mellitus in a patient. The type 1 diabetes mellitus we know the onset of type 1 diabetes mellitus in a young patient, in a young male, or female, The type 2 diabetes, on the other hand, we don't know the duration, how long the patient had the type 2 diabetes. We are not sure. So so any patient coming, whether it is type 1 diabetes mellitus or type 2 diabetes mellitus, coming to you for control of blood sugar or initial checkup for blood sugar, you found that patient is having high blood sugar, and that moment only you suspect the patient is having diabetic nephropathy. So almost all patients we see in type 2 diabetes mellitus will be having diabetic nephropathy because the onset might have had long back. Patient might have symptomatic now only. So type 2 diabetes mellitus, the moment you should see the patient, should think of diabetic nephropathy also. In type 1 diabetes mellitus, we'll get some more time. If you know the onset of the diabetes mellitus is that time, the onset of diabetes mellitus, you know, the time period, you know, and then it may take some years to develop the proteinuria and nephropathy, but we can regularly follow up the patient. So the primary thing is to suspect in all patients and rule out diabetic nephropathy in all patients with the diabetes mellitus, whether it is type 1 or type 2 diabetes. So if the patient, if you take the trajectory of type 1 diabetes mellitus, the patients, if it is less than 5 years, and you know the onset of diabetes, if you know the onset of diabetes mellitus in type 1 diabetes mellitus, if the patient is diabetic for less than 5 years or more than 25 years, it is unlikely that the patient is having nephropathy if the patient does not develop proteinuria. For example, if the patient is young patient, type 1 diabetes, you know the onset of diabetes mellitus, and it is unlikely that within 5 years that patient develop nephropathy. And it is also unusual or unusual that if the patient does not develop proteinuria in the first 25 years in the type 1 diabetes mellitus, it is unlikely that patient will progress to nephropathy. So the 5 to 25 years gap, we can suspect diabetes to develop diabetic nephropathy and rule out all other etiologies. So the rule number 1 is to suspect diabetic nephropathy in all patients, and the rule number 2 is rule out all other etiology. So how we should rule out other etiologies? So you know the trajectory. The patient is presenting to you for long-term diabetes, 10 to 15 years of diabetes, and the patient is presenting for edema, for a gradual onset edema for last 3 to 6 months or 1 year, and it is moderately increasing. And if the patient is having proteinuria also, it is, and the patient is having diabetic retinopathy and neuropathy, all the changes are there, and it should be diabetic nephropathy unless otherwise proved. So when you should suspect, when did you suspect other, when will you suspect other causes of other etiology of the other etiology other than diabetic kidney disease? One is if the patient is having disproportionate proteinuria. So suppose the patient is diabetic and with normal renal function, his creatinine is normal, but the patient is having gross proteinuria, nephrotic range proteinuria. So we should suspect something else is there. It can happen in diabetic nephropathy, but we should rule out some other causes of nephrotic syndrome in that patient. On the other hand, the patient is having renal worsening. A diabetic patient present to you with creatinine of 3 or 4, but the patient is not having any proteinuria. So we should rule out other causes. The most common causes coexisting with diabetic nephropathy is hypertension. So the patient can have hypertension nephropathy alone than without diabetic nephropathy, or it can coexist with vascular lesions, coexist with diabetic nephropathy. So the management of diabetic nephropathy and hypertension more or less same. So it doesn't matter that much if the patient is having diabetic nephropathy along with hypertension nephropathy. So if the patient is having proteinuria significant, if the patient is having significant proteinuria with normal renal function, if the patient is having worsening of renal function with normal proteinuria, and next thing is urine examination showing other than proteinuria, some active sediments are there. The patient urine routine showing albumin along with the active sediments. RBCs are there. You should suspect some other glomerular disease, glomerulonephritis. So presence of RBCs, significant proteinuria, and onset of symptoms. The patient was diabetic for 10 to 15 years, and now the patient is present with a significant edema of 1 week duration. Sudden onset edema. You should suspect some other causes. And associated with other symptoms that will be obvious if the patient is having diabetes and now the present with the proteinuria, but the patient is having fever, joint pain, rashes. So some systemic manifestations of diseases can affect the kidneys. So we should rule out that causes also. So rule out other etiologies in diabetes mellitus is important. And diabetic retinopathy, this is not always present. So if the patient is diabetic, it is not common that all the patients should have diabetic retinopathy changes. And diabetic retinopathy, early diabetic retinopathy may be missed, and it depends upon observed variation might be there. So diabetic retinopathy is not an essential feature of diabetic nephropathy. Now, whether we should do biopsy to identify or rule out other etiologies. We may do biopsy in certain situations to rule out other etiologies in strongly suspicious diabetic kidney disease. For example, this is one patient, 52-year-old male, female, presented with hypertension diabetes. She had 3+ proteinuria. Her creat was 1.1 and serum albumin 1.7. See, the patient, her creat is more or less normal, 1.1. And her serum albumin is 1.7, severe hypoalbuminemia and 3+ proteinuria. So here, as I said earlier, there is a strong suspicion of some other etiologies that she has severe hypoalbuminemia with normal renal function, significant proteinuria. So we did kidney biopsy, and biopsy showed nodular mesangial matrix expansion in all the available glomeruli, KW nodules and capillary microaneurysms, all things features suggestive of diabetic kidney disease only. There is no fibronecrosis, crescents, no spikes, indecision, and immunofluorescence was also negative. So this patient had diabetic kidney disease alone, but she had normal renal function with significant proteinuria and severe hypoalbuminemia. To suspect other than diabetic kidney disease, suspect other routine nephrotics, causes of nephrotics in adult nephrotic syndrome, other than diabetic kidney disease. But biopsy didn't show anything else. It was diabetic kidney disease, diabetic nephropathy alone. Again, one more patient, 15-year-old male with diabetic with nephrotic range proteinuria and diabetes mellitus. He has 4+ proteinuria. Creat is 1 milligram per deciliter, and urine protein creatinine ratio is 12.7. So here, similar patient, creat is 1, had significant proteinuria 4+, and urine PCR is 12.7. So we did biopsy because with the normal renal function, he has significant proteinuria. So we have a low threshold for kidney biopsy, and kidney biopsy is a safe procedure right now. We didn't have any complication till now. So unlikely, complications are unlikely if you're doing USG guided kidney biopsy. So this patient had nephrotic range proteinuria with normal renal function with diabetes mellitus. So see here, the immunofluorescence showing IgG 3+, granular positivity along the glomerular capillary loops. Okay, and on the light microscopy, there is spikes and pinholes on the glomerular mesenchymal membrane, and so there is no KW nodules, there is no IgG linear positivity. Usually in diabetes mellitus, there will be linear positivity IgG. So here, granular positivity 3+, and spikes and pinholes in the glomerular basement membrane with the thickening of the glomerular basement membrane indicates that the patient is having membranous nephropathy. So here, the same scenario, patient is having nephrotic syndrome, another etiology. So it is membranous nephropathy. So we did PLA staining for this patient, and it was found to be positive. So it was primary membranous nephropathy in a diabetic patient. So the treatment changes. Now, again, one more patient, 62-year-old female with nephrotic syndrome diabetes, proper proteinuria and the creatinine is normal, I don't remember exactly. Creatinine is normal and 24-hour urine protein is 7.8 grams. So it is again nephrotic range proteinuria, normal renal function, diabetes. So here, see the IgG1 plus linear positivity suggestive of diabetic changes. And on the glomerular light microscopy, there is segmental sclerosis of the capillary tuft at the tubular pole. So there is sclerosis in one of the glomeruli. So it is FSGS plus diabetic kidney disease. Now we have to rule out the cause of FSGS in this patient. So it is very well possible that these three sets of examples and these three patients had normal creatinine. All the patients had normal creatinine and the patient had varying degree of proteinuria and with biopsy in these patients with varying findings. So in certain patients, biopsy may be helpful. Now, shortly regarding very briefly regarding the treatment plan, we can divide the treatment plan like cardiovascular risk reduction, glycemic control, and blood pressure control, and along RAS inhibition and fluorescence. Now, cardiovascular risk reduction, we know everything almost like tobacco cessation and lipid lowering. Lipid lowering agent should be started for all patients. Weight reduction, all this salt and water reduction, protein reduction, all this can help in reducing the progression of the kidney disease. And glycemic control. So glycemic control, there are various studies available, both in type 1 diabetes mellitus and type 2 diabetes mellitus, that intensive control early in the management of diabetes mellitus will prevent adverse events later. So that is known as legacy effect. So if you manage diabetes mellitus aggressively and keep the HbA1c around 7, and even after 10 years, so even after 10 years, these effects can be the benefit of the early tight control of diabetes was observed even later in patients with diabetes mellitus in cardiovascular outcomes. So this is known as legacy effect. This was even evident in UKPDS and DCCT1 trials. So, and if you control the diabetes, there is no added advantage, and there were more complications if you keep the HbA1c less than 7. So it is more or less keep the blood sugars around HbA1c around 7. More than 7, the patient had significant hypoglycemic episodes and there were no added benefit. So HbA1c around 7 was the good range. And blood pressure control, there are 130, about 80 is recommended. JNC 8 recommends 148, okay, 140/90, less than 140/90. Okay, anyway, it should be definitely 140/90. Better to have 130/80 millimeters of mercury. Now, coming to the proper management of diabetic kidney disease, RAS inhibitions and fluorescence play a major role. So RAS activation is evident in diabetic kidney disease. So the primary target should be reduction of proteinuria, and the single most agent which is available to control proteinuria is RAS inhibitors. So it can be either angiotensin receptor blockers like telmisartan, losartan, ACE inhibitors, ramipril, enalapril, direct renin inhibitors like aliskiren, direct renin inhibitors are the, and mineralocorticoid antagonists or mineralocorticoid receptor antagonists are the spironolactone, eplerenone. All these things will inhibit RAS activation. RAS activation will decrease the intraglomerular pressure, and intraglomerular pressure further reduce the proteinuria. So once the proteinuria is reduced, further progression of nephropathy, chronic kidney disease can be reduced. And almost multiple trials are conducted with ARBs, ACE inhibitors in diabetes mellitus, and these are found to be useful in all stages of proteinuria. For example, if the patient is diabetes, there is no proteinuria and reduction of proteinuria. reduction of microalbuminuria was observed in patients with diabetes mellitus. Patients with microalbuminuria, progression to macroalbuminuria was prevented with, not prevented or reduced with RAS inhibitors. Patients with macroalbuminuria on RAS inhibitors found to have lesser advanced CKD, lesser cardiovascular adverse effects. So RAS inhibition is a core of the treatment of diabetic nephropathy and should be prescribed to all patients at the early stages. Whether there is proteinuria, whether there is hypertension, patient should be on RAS inhibitors. So if you find a patient with the diabetic nephropathy, and if the patient is tolerating RAS inhibitors, suppose the patient is not tolerating, we can't increase the dose. So tolerable ARB inhibitor, AC inhibitors should be prescribed to all patients with diabetes and proteinuria. So reduction of proteinuria can be combination of angiotensin receptor blockers with AC inhibitors or renin inhibitors, but this is not useful. This is useful to reduce the proteinuria, but found to have significant adverse effects like worsening of renal function, hyperkalemia. So it is not recommended. So independent of blood pressure control, the patient is benefited. So you find that patient is having diabetic nephropathy, patient is having normal renal function, but patient is having proteinuria, coming to OPD, and you check the blood pressure is 110/70. But we are supposed to start on AC inhibitor or ARBs at the earliest. Coming to fluorescence, we didn't have anything other than AC inhibitor or ARBs for years, like so 10 to 30 years, we didn't have anything other than AC inhibitors. So recently we have this SGLT2 inhibitor. These drugs are known as fluorescents, canagliflozin, empagliflozin, dapagliflozin. So this dapagliflozin is available now. So these drugs are known as fluorescents, and these are found to have significant effect on proteinuria reduction and decrease in the cardiovascular outcome, adverse outcomes, and reducing the end stage renal outcomes. So better renal outcome, better cardiovascular outcome, better proteinuria reduction with SGLT2 inhibitors. So this was even in non-CKD, non-diabetic CKD patients also. So these SGLT2 inhibitors are sodium glucose cotransporter inhibitors. Sodium glucose cotransporter inhibitors are there in the proximal convoluted tubule. So in PCT, these SGLT2 receptors will absorb your sodium and blood sugars. So once SGLT2 are administered, so this reabsorption won't occur, and this glucose will pass through the urine. So glucosuria will be there. So there will be these drugs are introduced as oral hypoglycemic agents, but these are found to be very useful in preventing CKD even in non-diabetic kidney disease. A DAPA CKD trial has published even in non-diabetic patients, these drugs were useful. So these SGLT2 inhibitors are game changers right now in the management of diabetic nephropathy. So all the patients right now should be on ARBs or AC inhibitors along with SGLT2 inhibitors in the management of diabetic nephropathy. So very less adverse effects. There are some, if the glucosuria is there, some patients may some genital infections are seen in some patients, and in type 1 diabetes mellitus is very rare ketoacidosis are seen, but we have never seen any such cases. So fluorescents and ARBs should be prescribed to all patients. So briefly discussing some other agents, finerenone. Finerenone is a melanocorticoid receptor antagonist. It is a non-steroidal antagonist. Steroidal antagonist we know spironolactone eplerenone. So we have this new drug finerenone. It will inhibit the melanocorticoid receptor specifically, and it is more potent, and side effects are lesser. The T half is lesser, and it is found to have better cardiovascular and proteinuria reduction. Proteinuria reduction. 2 trials were published recently: the Fidelio trial, Fidelio trial, and Figaro trial. So both were found to have one with proteinuria reduction, one with good cardiovascular outcome. But this compared with this finerenone versus placebo, finerenone versus placebo, and both groups they were added AC inhibitors. So the outcome was good, but not as good as fluorescents. SGLT2 had good outcome than Finrenone. So Finrenone, so one pharma company has introduced Finrenone in India, but it's costly oral tablet. So GLP receptor antagonists and DPP4 inhibitors are found to be other than, so these two drugs, group of drugs will work on the basis of incretin levels. So GLP should be there, and this GLP will be it's a sort of incretin. So once we take the food, the incretin levels will increase, and this will modulate the insulin levels, glycemic status in our body. So this GLP should be there, but it is degraded by DPP4 inhibitors, DPP4 enzyme. So GLP agonist and DPP4 inhibitors, these two new drugs are introduced to prevent hyperglycemia, but they have an effect on kidneys to prevent the progression of kidney disease. So like these are like direct and indirect effects. So they will prevent the hyperglycemia, hypertension, obesity. So in the kidney, they have direct effect, like reducing the oxidative stress, reducing the inflammation, and prevent the natriuresis, and reducing glomerular hypertension. So there are some direct effects on the kidney to reduce the worsening of renal function. And PCSK9, these were recently studied molecules, so to decrease the lipid levels, and these also found to have some effects. But these drugs we never used to prescribe routinely. So this is regarding use of Finrenone. Finrenone, if the patient is having diabetic kidney disease, patient should be on RAS blockers. Even if after RAS blockers, if the EGFR is more than 25, if the EGFR less than 25, Finrenone is not indicated. If the EGFR is more than 25, we can suggest Finrenone. Finrenone is a mineralocorticoid receptor antagonist, can have high potassium levels. So if we combine with AC inhibitors, the risk of hyperkalemia should be there. So potassium should be monitored in all patients. So, so the protocol, this was published in Therapeutics and Clinical Risk Management, July 2022. So the protocol is to add SGLT2 to RAS blockers for albuminuric diabetic kidney disease if the EGFR is more than 25. If the SGLT2 inhibitors use is contraindicated, then add Finrenone to RAS blockers. Okay. So this is regarding Finrenone. So so this is like basic outline to how we manage diabetic nephropathy. I purposefully avoided CKD, means diabetic kidney disease progressing to end-stage renal disease and dialysis management. That management is not needed, I think. So I'll discuss one case scenario. A 56-year-old male with a type 2 diabetes mellitus for 20 years on glimepiride and metformin. Now metformin. Controlled blood sugars, presented with the pale edema of recent onset, create 1.3 milligram per deciliter. No previous creatinine reports on amlodipine 10 mg for last 5 years. So this is the most common scenario where a periphery patient will come to a primary care team. A patient will have diabetic on glimepiride and metformin, controlled blood sugars. So the patient is having pale edema. Because of pale edema, he might have checked the creatinine. Creatinine is 1.3. The patient won't have, this is one mistake, that the patient is having 20 years diabetic. He has not checked, the creatinine is not assessed previously, and proteinuria is not assessed previously. And the patient is on glimepiride and metformin. The patient should be on SGLT2 inhibitors at present. So if you ask me, I will stop glimepiride and change to SGLT2 inhibitors for the patient, even if I don't know anything. If the patient is beginning with a diabetic in a 56-year-old male. So here creatinine is 1.3, no previous creatinine reports. So we cannot assess whether it is what was the previous reports on amlodipine 10 mg. So how will you approach? So first we should do urine routine to assess the urine routine, urine PCR or urine ACR. We should do to assess the proteinuria. If the proteinuria is there, it will satisfy diabetic kidney disease. So diabetic kidney disease is there, proteinuria is there, and the patient should be on metformin, SGLT2 inhibitors, and we should add ARBs or AC inhibitors here. And if the patient is we should work up for other causes. We should evaluate for diabetic retinopathy and neuropathy, and we should see the kidney size also. Usually, in kidney size will be maintained in diabetic nephropathy. In other CKDs, kidney size will be contracted. Kidney disease, diabetic kidney disease, diabetes is one condition where in CKD the kidney size will be increased or maintained. So we should add AC inhibitors, and we should monitor potassium and creatinine on the follow-up visit, and we should add small amount of diuretics to prevent the edema, and we should add SGLT2 inhibitors in the patient, and we should follow up with the proteinuria. And we should look for other macrovascular complications. Echo, peripheral neuropathy, retinopathy should be assessed. 60-year-old lady with hypertension, losartan, 50 mg PD, and diabetes, and hypertension, diabetes mellitus on insulin, dapagliflozin with a creatinine 2.6 milligram per deciliter, urine 3 plus albumin, and RBCs 30 to 50 RBCs, and pale edema. 1 month ago, her creatinine was 1.6. So how will you approach? Definitely, we know that there is a strong suspicion of something else, because 1 month back her creatinine was 1.6, creatinine now is 2.6, so it is increased, and there is albuminuria and RBCs in the urine. So we should look for some causes other than diabetic kidney disease in this patient. So when there is RBCs, we should rule out glomerular nephritis, we should rule out infection-related glomerular nephritis or some other sort of glomerular nephritis, and we should work for that, whether C3, ANA, or maybe a kidney biopsy may be indicated. So the pattern is different here. So we should rule out other causes of worsening of renal function in this patient. So this one is the last slide. A 45-year-old male, type 2 diabetes for 7 years and has been well controlled. He also reports hypertension for past 5 years and been under good control. BP is 135/75, losartan 50 BD, metformin 1000, and glimepiride 1 OD, 1 milligram OD. Serum potassium 5.1, creat 1.5, albumin creatinine ratio 1257 milligram per gram, and HbA1c 6.9. So diabetic for 7 years, HbA1c 6.9, well controlled. Hypertension 5 years, BP is controlled. He's on losartan, okay, and he is on metformin, good. Glimepiride, good, and so no dapagliflozin. Anyway, he's on ARB. So here the creat is 1.5, mildly increased, and proteinuria is not controlled. See, proteinuria is still high, 1257. So which one will you choose? Add an AC inhibitor to the regimen with goal of decreasing proteinuria, ACE inhibitors, already ARB. Stop metformin as creatinine increase, replace glimepiride with dapagliflozin. Stop losartan as creatinine is increasing. So the first one, add ACE to the regimen. Won't be a good option because the potassium is already 5.1. The patient is already on ARB. So ARB ACE inhibitors will reduce the proteinuria, but it's not a good combination in this patient because of hyperkalemia, and in all patients, because in our patients we are following up the patients monthly. They won't come in between. They won't check potassium also. So better not to start combination ACE into the ARBs. Stop metformin as creatinine is increased. Metformin is not contraindicated in renal failure because metformin we can continue. So the guideline says if the GFR is less than 30, we should stop. We should not start metformin, but even CKD patients, metformin well tolerated. I didn't see any lactic acidosis in patients with CKD, ESRD patients also. We gave metformin. Metformin is say very good drug, particularly for diabetic type 2 diabetes. So metformin should be continued. Creatinine increase is not a contraindication for metformin. Replace glimepiride with dapagliflozin. I think I will take this option as correct because glimepiride, if the creatinine is increasing, the chance of prolonged hypoglycemia is higher. So glimepiride should be replaced with the dapagliflozin, and dapagliflozin should be there because the patient is diabetic and proteinuria is not controlled. So patient should be on dapagliflozin at present. At present, no, at present means at the point at this time period, with the evidence we have, all the patients with diabetic nephropathy should be on SGLT. Tolerable patients on. If the patient is tolerating, patient should be on SGLT2 inhibitors and ARBs. Stop losartan as creatinine is increasing. Losartan should not be stopped as creatinine is increasing. We can monitor for hyperkalemia and worsening of renal function. We can continue losartan even if the creatinine is worsening. Creatinine is worsening due to progression of diabetic kidney disease. So even if the creatinine is mildly increased, we can continue losartan. It is not a contraindication to stop losartan, but hyperkalemia is a risk factor to stop losartan. So with this, I will wind up. So the take-home message is creatinine may or may not high in diabetic kidney disease. Patient can have elevated creatinine, normal creatinine in diabetic kidney disease. Patient should not have increased creatinine to diagnose as diabetic nephropathy. Suspect in all patients with diabetes mellitus, but rule out other causes. Diabetic retinopathy may not be evident in all patients. All patients should be on RAS blockers, whether ACE inhibitors or ARBs, plus fluoresceins. Dapagliflozin should be there in all diabetic patients. So refer to nephrologist on time. So that actually, so if you found that creatinine is increasing and the treatment plan, if you the treatment plan will be treatment policy will be same if we know the guidelines are there. But thing if like till renal replacement therapy or till the dialysis requirement, the management by a physician, the management by a family physician, the management by a nephrologist won't differ much. But the issue is to discuss the future plans. Future plans means eventually the patient will progress to diabetic nephropathy, end stage renal disease. Patient will require dialysis or transplant. So better to refer to a nephrologist if the patient is progressing to ESRD. If the patient is progressing to ESRD, we should refer the patient very well before the indication for dialysis. So the patient can meet a proper team and they can create an AV fistula or catheter or transplant plan, whatever it may be, can plan future options. So on time referral may be good. So with that, I will wind up. Thank you all for patient listening. This, I know this is not a big discussion. I just discussing some few points which all might be knowing. Thank you all once again.
Thank you, sir. Next, I invite Dr. Vijay Raj to give your valuable comments.
Thank you, Dr. Dhanin, for the most wonderful talks I've come across in recent times. It was very succinct, and I think you have to keep this in mind that this is a historic talk which you have given. Being the first regular CME program planned for the North Zone of the Academy of Family Physicians of India, Kerala chapter, North Zone. I don't think we could have.
Thank you for actually inviting for. Thank you for inviting.
Frankly, I don't think we could have asked for a better speaker and a better talk. I can see, I suspect you are in your car giving this talk.
Actually, I was about to reach one place. I was middle of nowhere right now. Actually, I had to attend one seminar, so I couldn't reach there. So I was supposed to present from there.
Could I take about 10 to 15 minutes of your so much valuable time?
Yes, sir, definitely, sir.
I request the people who are attending. I think there are more than 80 participants, 85 at its peak, I suspect. Thank you for highlighting the practical aspects in a case-based manner. One important take-home message which I would like to highlight here is we in peripheral practice tend to just look at the creatinine value and push off the patient as having probably no CKD or DKD. I would like to highlight the role of proteinuria, which I have mentioned in your talk multiple times. Please go through the guidelines once again to all the listeners. We underestimate the role of, like, I'm telling it's for the listeners actually. We frequently underestimate our own role of gatekeeping in detecting CKD or DKD early enough. We do detect them when the creatinine is raised, but most of the time it is a bit too late for the patient. So we have to monitor creatinine and proteins periodically. There was a question by Dr. Abdul Basit asking how frequently, sir, we should be monitor creatinine or microalbumin.
Yeah, actually, we can. It depends. Actually, if the patient, we usually monitor.
Suppose a patient is not having any previous problem. Is once a year okay?
Yes, definitely. Once a year is okay. If the patient is not having any albuminuria,
Yeah, fine. Thank you.
once a year is okay. So we used to monitor. Like our patients will be profile is different. Our patients will be bit more they might be progressing the end stage. So creatinine is high. So we used to call them every month. So creatinine is 4, 5, like between 6 and 7, and most of the patient will be on SGLT2 and no, it's not SGLT2, on ARB. So we're worried about the creat and hyperkalemia in this patient. So we used to call them every month, and we had to plan for dialysis also. Other than that, if the patient is having diabetes alone, they can even proteinuria assessment and retinopathy assessment. They can once in a year they can do.
Okay. There was a question by Dr. Nikhil Patnaik. He asked on the lines of you mentioned that, and it's also important take-home message, that AC or ARB should be started in patient with risk, irrespective of the hypertensive status. That is, in normotensive patients, you should give AC or ARB. So we, in our practice, we find people with BP of say 110/70. So would you recommend starting say telmisartan at 20 mg or 40 mg straight up in these patients?
We used to start. I used to start personally 20 mg telmisartan. If we are starting telmisartan, we'll start on telmisartan 20 mg. The most common side effects will, if the patient is not tolerating postural hypertension, postural symptoms. So rather than starting at morning time, we can start at bedtime. So 20 mg at night will start, and most of the patient will tolerate. Their BP won't reduce unless the physician, I mean the person at the medical shop, tell them that it is a drug which reduces the BP. Why you're starting hypertensive drugs, the BP is normal. So we should clearly explain to them this is for something else, and we can start on telmisartan 20 mg very well. They will tolerate even if the BP is 110/70. But if the patient is symptoms, if the patient is not tolerating any symptoms of hypotension, giddiness, like postural symptoms, we should stop. Definitely, we should not do harm with the.
There's a question by Dr. Nadeem. He's asking whether there's any added benefit of increasing the dose of ARB or AC from the dose which patient is already taking. Suppose the BP is normal, the patient is already on say losartan 50.
If the BP is normal, whether like the best thing will be to assess the proteinuria. If the proteinuria is very well controlled, we can assess the proteinuria. If the ACR or PCR we are seeing, if it is less than 0.2, or if the proteinuria 24-hour proteinuria is less than 30, it is not in the microalbuminuria level. So we can assess. Or if the patient is well controlled proteinuria is not increasing. Suppose the patient can tolerate 80 mg telmisartan, but with the 40 mg, his proteinuria is negligible. So we'll continue with the 40 mg.
Is there any benefit in increasing the dose of the medicine? Will it retard the progress of proteinuria or CKD if we increase from the already existing dose?
Yeah, definitely it will reduce the proteinuria. So if the proteinuria is increasing, we should definitely increase the dose of AC inhibitor or ARB. So if you ask me, no studies might have done to start normal proteinuria. All patients means patients with normal proteinuria with different dose of telmisartan. Higher dose had reduced cardiovascular and renal outcome in the later. That might be the question. So that studies are not there. So if proteinuria is increasing, we should increase the dose. And if the BP is not controlled also, we can add. Other than that, if the BP is controlled and proteinuria is normal, whether it's two sets of persons with higher dose of ARB and normal dose of ARB, which have a better outcome, probably might be there. I don't think any studies are there on that side.
So I really hope you have some more time on hand because the questions keep on coming to you. Dr. Roby has asked from Calicut, what is the role of diuretics in CKD? in people who have edema, especially?
Diuretics have a role in edema only. There is no role in CKD. If the patient is having edema, so the concern is that some of them, if you give diuretics, the creatinine will increase. There is no such things. I have never seen. I have seen my practice that creatinine is increasing with the diuretics. Diuretics should be prescribed with the symptoms. If the patient is having edema, diuretic should be prescribed, and the dose of diuretic should be higher. So if you start on furosemide or torsemide, you start on 10 mg in a normal patient, normal creatinine, the dose requirement in CKD will be higher because the drug should reach the thick ascending limb of loop of Henle. If the patient is having renal failure, suppose the create is somewhere around 3 or 4, the dose should be much more, somewhere around 20 or 40 we should give, higher dose we should give. The drug reaching the distal thick ascending limb of loop of Henle will significantly reduce as the creatinine increases. So if the patient is having edema, we should add diuretics. There is no role for retarding the progression of CKD. There is symptomatic management only.
Okay. So I think our time is up now. I think more than us, you are busy. You have a different program to attend in some time. Do you, if you have time, we would like to continue with the questions. About 10 more minutes, 5 minutes maybe.
Yeah, 5 minutes we can.
Okay, thank you, sir.
So,
yeah, Dr. Ashwati had asked previously, what is the role? Would you stop fenofibrate in a person with, say, a raised creatinine maybe of 1.5?
Yeah, this is actually fenofibrate. I will stop fenofibrate. This is not not coming under this topic. So fenofibrate has chance to increase the creatinine, and it is reversible usually. We'll stop the fenofibrate used to reverse the renal function.
Right.
The worst creatinine will come back usually, come back to normal. So we can use alternative agent.
So albumin to creatinine ratio versus protein to creatinine ratio.
The studies are shown both are equal. The problem is both are found to be. The basic problem is if you take I used to do both the urine routine examination and PCR or ACR. ACR bit costly. ACR we don't have available in our hospital, so they have to do outside. So PCR we used to do. So we will have a correlation between urine routine and PCR. The problem is we used to see urine albumin nil or urine albumin 1+, but PCR is showing 20 or 30. So how this happens? PCR is a examination which can have errors in the sense that protein creatinine ratio, they are taking total the protein estimation and creatinine estimation. So most of the time the error comes in the denominator, creatinine. So the basic principle is that if we see the PCR is high, we should see the creatinine, means urine creatinine. Normally in adult male will have a creatinine of 25 milligram per kilogram body weight excretion in the urine, and female will have somewhere around 50 milligram per kilogram body weight of creatinine. So if the creatinine is too less, minute errors can have higher PCR values. So I used to correlate between urine routine and urine PCR at present because we don't have ACR. ACR and PCR found to be equally effective in one large randomized controlled trial. But ACR is found to be more sensitive in recent trials, and most of the guidelines, KDIGO guidelines, kidney guidelines, suggest ACR. So if you ask me which one is the best, I would suggest ACR, albumin creatinine ratio, considering creatinine should be and properly measured, urine creatinine.
So one last question from my side. There's a small question actually. Why are drugs like aliskiren or aprelinon or that group, do you think it's underutilized in primary care or in general care? I suspect
aliskiren actually,
the aliskiren entered the market about 10 to 15 years ago, right?
Yes.
But
yes,
for some
actually,
reason,
yeah, aliskiren, I don't know what happened exactly. Any reason was that it was withdrawn? I'm not sure whether price or some adverse effects. I don't remember exactly.
it was costing
Aliskiren,
about
I never used actually aliskiren. And regarding spironolactone and eplerenone, they are using. We are regularly using spironolactone and eplerenone. The concern is hyperkalemia because already the patient will be on this ARBs. So adding ARB and potassium sparing diuretics, again, chance of hyperkalemia is there. Regarding spironolactone and eplerenone, more cardiac benefit is there. So most of the patients with from cardiology side used to see even eplerenone and spironolactone I've seen. But if we combine, means in the early stages of CKD, as the CKD progresses, we are worried about hyperkalemia. So the dose reduction, and one of them will be stopped, most probably spironolactone, I think. Spironolactone is used. Aliskiren, I know, used actually.
So you mentioned the role of water restriction in CKD. At what stage or what phase of the
Again, this diuretics and the water restriction go hand in hand. Salt restriction is something different. Salt restriction we do it for control of blood pressure, and control of blood pressure will reduce the progression of kidney disease. So BP control, salt control, BP control, kidney control. The water and diuretics go hand in hand. If the patient is having edema, we reduce the water intake. That's all. If the patient is having edema, we start on diuretics. Other than that, if the patient is having good urine output, if the CKD is tubulointerstitial disease, for example, some patients will be there, some tubulointerstitial disease CKD till create 10, 8 to 12, 14 create will be there, but patient is having good urine output. Urine output will be maintained. Such patients, we don't require that much water restriction. We'll start on diuresis because of uremic symptoms rather than that of congestive symptoms. So water restriction based on body volume status.
Okay. So I think I'll take one last minute of your time again. Dr. Mansoor had asked, if you start AC or ARB, there might be a slight rise in creatinine in some people.
Yeah, definitely.
It's a common practice in observation in the periphery that we GPs tend to panic with the moment the creatinine goes up.
Yeah,
and the
that is a problem actually. So there is a problem actually. It is too difficult to convince the patient. So what I used to write patient concern. So they stopped like that. We can't do it. So it is expected to reduce. GFR definitely will come down. So up to 20 to 30% GFR will come down initially when you start the drug. So if it is not happening in the initial period, it is quite unlikely that it happens on the follow-up phase. And on the follow-up phase, it is happening due to the progression of kidney disease only. Kidney disease will be anyway progressing. We are anyway will progress. We are reducing the rate of progression only. So initial stage, we'll tell the patient. Anyway, we won't tell the patient. We'll start the patient and we'll ask the patient to come back with the creatine potassium within 2 weeks. If it is not increasing more than 20%, if it is 20% only, we'll definitely will continue with the AC inhibitor or ARB. If it is more than 50% or very much hike is there, we'll stop it. Because and one more thing, all patients, if you get time, we should explain the patient. Educated patients, I used to tell that if the patient is having any diarrhea, loose stools, or hypotension, we should stop the ARB. So any volume depletion state, the perfusion to kidney will be reduced. At that stage, if you are continuing on ARB, there is a chance that create may go up. So all the patients will have 20% increase in, will continue ARB. In between, mild increase in creatinine will be mild, more probably because of the increasing worsening renal function. And if the patient is having diarrhea or volume depletion, we should definitely stop the ARB.
Yeah. Thank you, Dr. Dhanin, for the such a patient redressal of all our doubts. I think most of our queries in the chat box have been covered, and a few from my side also. I think it's
such a sad thing that it's an online talk. We can't give you a physical memento for making our evening so memorable. But surely we'll meet in person sometime as a group. Yeah, definitely. And we'll make it worth it. For now, I think we'll have to etch this online talk, however humble it might be in our memory. Right. So thank you, Dr. Dhanin. And I think it's one of the best proofs of the quality of your talk was that out of 80 who attended, somewhat around 80, more than 65 has stayed even till this minute. 75% attendance in the last minute of the talk is really a great super hit talk. Thank you again. And congratulations to the organizers, Dr. Nigesh, Dr. Prashop, and everyone who thought of this idea and thought of calling Dr. Dhanin as our speaker. I think we have to. I'm closing up my my part with a couple of lines. I think it's a big responsibility on our part as family doctors and peripheral practitioners
And we have to take up this responsibility of making sure that we pick up CKD or diabetic kidney disease in our practice population in a very, very early stage. Now, there's also a stage in many people in the early part of CKD or DKD, where the GFR might improve actually. Sir, please correct me if I'm wrong, but if that happens very early in the illness. That last year the GFR was around 85, and this year it is around 110. And we and the patient might tend to be happy that okay, the kidney function seems to be improving, but actually that might be a false alarm and an ominous sign of things to come, especially if the lifestyle factors or the diabetes or hypertension are not adequately controlled. So with that couple of lines, I would like to end my tirade. And thanks again, and congratulations to the organizers for a splendid evening. Thank you so much. I hand over to Prashobh, Nigesh, and Dr. Navina.
Thank you so much. It was such a enlightening session, especially with the inputs from Dr. Vijayaraj, and Dr. Dhanin has been with us for such a long time, addressing all our doubts, and he has been very patient, and we can see that he's very busy, but still he has given his time for us. It was a really wonderful session. Thank you all the participants for being with us, and I hope you all enjoyed, and please do give your feedbacks. I think we can, Dr. Nigesh, shall we end up the session?
Yeah, sure. Let me give the vote of thanks. And hello, am I audible?
Yes, sir, you're audible, sir.
Okay. So we all know that the cases of diabetes are increasing like anything, as are the complications. And we as a family physician, being the first contact for all the patients, we have to detect those subtle changes that already sir has discussed, like microalbuminuria, okay, and must be able to manage them and detect them at the early stage. Since most of the nephropathies, we know the damage that has been done we might not be able to reverse back the changes. So it is very important that we have to detect them in their early stages. Okay. And Dr. Dhanin has given an excellent, clear, and crisp presentation of the topic. Thank you very much, sir. In spite of his busy schedule, he has given these insights, and I hope everyone will take home the message given, especially the PGs and the newcomers, and apply them in their daily practice. Thank you so much, sir. And I also like to thank Dr. Vijay, sir. He is the founder president of the AFPI. He was always there for us as a mentor, as a guide, or everything. Thank you, sir. I also like to thank Dr. Indu. Indu ma'am has inaugurated our session. And also I thank Dr. Rashmi, Dr. Serin, the national, the Spice Food Chair, and also Dr. Navina, Dr. Prashobh, and all the participants and all those who have been in the process of making this function a grand success. Thank you, everyone.